Now the next talk will be by Professor Fatin Fauzi, Brain Tumor Reporting and Data System in assessing post-treatment glioma response.
Thank you, Professor Dr. Hisham. It's my proud to be a part of this great event. My presentation is about the assessment of post-treatment glioma response with brain tumor reporting and data system, the BT-RADS. MRI has played a crucial role in management of patients with brain tumors, but challenges in differentiating tumor progression from post-treatment changes and treatment response can cause inconsistent interpretations, limiting the usefulness of imaging. The development of a standardized reporting system in line with clinical management patterns is an opportunity to significantly improve radiology reporting in brain tumor patients. Other advantages include the physician preference for standardized reports, incorporation for clinical decision support, and clear communication between physicians, radiologists, and patients. Specific imaging and clinical criteria are required for applying this reporting system with the aid of a team of neuroradiologists, neurosurgeons, and neuro-oncologists. So a scoring system ranging from 0 to 4 for follow-up studies was applied by Weinberg et al., and it was published in the Journal of the American College of Radiology. Each is linked with a specific measurement suggestion, the interpretation based on conventional MR findings regarding the flare, post-contrast enhancement, edema, and the mass effect. This table summarizing the scoring system from 0 to 4 take care that the green zone, we are in the safe side. Here, you continue follow-up of our patients, and there is no change in the protocol of treatment. Score 3, in which there is imaging worsening, there is the yellow zone. Here we have to decrease time interval follow-up or to add other imaging techniques till we reach the dangerous zone, which is the imaging worsening. Here you have to consider change in your protocol. Score 0, PET 0 equals the non-scoring. It is a baseline study. It is non-diagnostic, but it is essential for subsequent follow-up. Score 1 equals improvement. 1A means actual or true improvement, in which there is improvement of the imaging findings that reflect decreased tumor burden and or improving treatment effects. So there is reduction in flare edema, decreased enhancing component, unchanged or decreased mass effect, no newly developed lesions, and the patient is clinically stable, so you have to continue follow-up and no change in treatment. Score 1B is a medication effect, which is called pseudo-response. This is false improvement. It is improvement subsequent to medications such as steroids or anti-angiogenic agents. You can detect reduction of the enhancing component, unchanged or increased edema, and so edema here is considered to be more important than the pattern of enhancement. No enhancing lesion, patient is clinically stable, and he is on increasing dose of steroid or any antiogenic agent. So don't forget to ask your patient about any medication. Continue your follow-up. Score 2, no appreciable change relative to the baseline or the previous studies. You have to continue follow-up. Score 3 equals imaging worsening. This worsening could be subdivided into A, B, and C. A, favor treatment effect, which is called pseudo-progression. This is false worsening. The false worsening of the imaging finding occur within the 12 weeks that favor to represent mix of chemoradiotherapy changes. This is what's called the post-radiation changes. You can detect the increase in the thickening of the enhancement around central necrotic cavity, and also there is no newly enhancing outside the treated zone, increased edema, increased mass effect, but the patient is stable and within the 12 weeks. Here you have to reduce time interval follow-up or to add other advanced imaging techniques. Score 3B is indeterminate, which is a mix of treatment effect and tumor worsening. Again, you have to reduce time interval follow-up. Score 3C favor tumor progression. The imaging worsening here favor to represent increasing tumor burden. Here, the increased enhancing component and flare edema, but it is still less than 25% of the sum products of the perpendicular diameters, and there is increased mass effect, edema, and the patient is clinically worse. So consider change in protocol of treatment and decrease time interval follow-up till we reach score 4, which is actual progression. And here there is worsening of the imaging findings with increased enhancement, increased edema, mass effect, patient is clinically worse, so consider change in your protocol of treatment. Baseline images are very important for first interpretation. Here, this is the surgical cavity. It is filled with CSF on different sequences. There is a heterogeneous signal area at the operative bed with corresponding enhancement and diffusion restriction. This could be attributed to post-operative changes. So PET 0 is the need to continue follow-up after 3 months. Here, on 3 months, there is increase in the size of the surgical CSF-filled cavity. Look here, there is T2 flare mismatching. This mismatching is a risk factor for tumoral activity. Here, the CSF cavity is not iso-intense to the CSF, but it is higher in signal, with increase in the enhancing component, about 25% of the sum products relative to the baseline, and corresponding tumor restriction on diffusion, so it is PET score 4. Timing evaluation is essential to be done within the first 12 weeks after completion of therapy. What is RANO? RANO is another classification system for post-treatment changes. It is a response assessment in uro-oncology, and it is updated in 2010, and it's subdivided into same as BT-RADS, complete response, improvement, partial response, stable disease or stationary findings, till we reach the progressive stage. Baseline images revealed the presence of area of restricted diffusibility at the operative bed with perilegional edema. Follow-up 12 weeks later, there is increase in the size of the area of restricted diffusibility with T2 flare mismatching. Here, this points to tumor progression, so it is PET score 4. The baseline images for an operated case with high-grade glioma revealed periregional edema reaching the splenium of corpus callosum with heterogeneously enhancing area. You have to continue follow-up on conventional sequences. Later on, we detected there is much increase in the perilegional edema, filling the splenium of corpus callosum, crossing the midline, and here there is lack of enhancement. The lack of enhancement and the presence of increased edema is considered to be a risk factor, and this points to the presence of pseudo-response, which is a false improvement. We can confirm the results by the addition of diffusion. Here there is corresponding diffusion restriction on diffusion weighted and ADC map. So what is this pseudo-response? It is false improvement. Again, edema is considered to be a risk factor, especially on follow-up studies. There is much increase in edema relative to the baseline flare with increasing mass effect. Edema here is flaring the gray-white matter interface, so it is a very important risk factor even in the absence of any contrast enhancement. We can differentiate tumor progression from the pseudo-progression by the new advanced imaging techniques. Here there is heterogeneously enhancing lesion around the central necrotic cavity, could be progression or pseudo-progression. MR spectrum revealed elevated choline peak together with lipid and lactate. Choline indicates cellular and vascular activity. And on perfusion studies, there is drop of the signal on the time signal intensity curve. So this is actual tumor progression and not pseudo-progression. Pseudoprogression again is subsequent to chemoradiotherapy changes, and it occurs 3 to 6 months after completion of treatment. It results into thickening of the enhancement around the tumor margin and increasing edema and mass effect. So take care that in immediate post-operative and follow-up studies, there is gradual increase in thickening of the enhancement around the central necrotic cavity with gradual increase in the perilegional edema. Later on, after 3 to 6 and 12 months respectively, there is gradual decline in the enhancement and the gradual decline in the edema. So this is a pseudo-progression based on conventional MRI, which could be confirmed by MRS. Here there is no choline peak at all. Lipid and lactate points to the post-radiation changes and a plateau vascularity curve on time signal intensity, so it is a pseudo-progression or post-radiation changes. This case is a typical example for progression and pseudo-progression in the same setting. The operative treated bed with heterogeneous enhancement around central necrotic cavity, but no corresponding diffusion restriction, apart from small area of diffusion restriction that could represent ischemia or post-therapeutic changes. And here there is increased edema. So there is edema, but no corresponding diffusion restriction. So this is considered to be post-radiation or pseudo-progression. On the contralateral side, there is a newly enhancing lesion with corresponding restriction. So here there is progression and pseudo-progression in the same setting. Pseudo-response again is subsequent to medication, so don't forget to ask your patient about any medication taken such as steroids or anti-angiogenic agents that restore the blood-brain barrier, result in reducing the blood supply, normalization of tumor vessels, and reducing the perilegional edema and enhancement. Like this case here, the baseline images revealed avid enhancement with perilegional edema on flare, but here there is just traces of contrast within the lesion, and there is much increase in the perilegional edema. So lack or reduced enhancement with increasing edema are considered risk factors that need further assessment with the advanced techniques. Another example here for perilegional edema and enhancing lesion, then the edema is the enhancement is reduced, but there is much increase in edema and the mass effect. So this is pseudo response. What about your reporting template? This is the ideal report for post-treatment. Just 2 minutes.
2 minutes.
Your report should fulfill the following criteria: the title, MRI of the brain, what is the clinical indication, tumor type and mutation, surgical history, radiation history, any medication taken such as steroids, detailed description of the technique and sequences used, the last comparison date, and then findings as regard T2 flare signal in the operative treated bed and perilegional, the edema and mass effect, enhancement if it is present or absent, diffusion, perfusion, MRS, and other findings. Don't forget to write your conclusion or impression at the end, status post-treatment, and what is PET scoring relative to the ligand attached at the end of your report. Finally, I will conclude that the evaluation of treatment response is challenging in neuro-oncology, so the radiologists aim to identify predominant component of lesion and categorizing the findings depending on RANO and PET scoring for the patient to receive the appropriate treatment. Remember the following points. The time elapsed between completion of radiotherapy and imaging acquisition should be taken in account before interpretation of post-treatment imaging. Increasing T2 flare edema around treated bed outside the 12 weeks of therapy is a risk factor for tumor progression. Lack of enhancement with corresponding increase in edema points to pseudo-response. Don't forget to use the advanced techniques such as MRS, diffusion, and perfusion, and other studies for accurate results, and to compare the data from multicentric studies aiming to modify PET scoring and RANO assessment for post-treatment assessment. Thank you so much.
Thank you, Dr. Fatim, for such a difficult topic, and you did it well all through. Now we move to the next speaker, Dr. Ahmed Reda Basuni from Mansoura University.